Ladies and gentlemen, dear attendees to this EPC, in the name of my co-chairs, Patrick Michel and Natalia Karashenko, I would like to welcome you to this final session of the EPC 2022 in Kiev, Ukraine, final scientific session, of course. Let me thank Natalia Gubergritz and her team for organizing such a fantastic conference, despite the terrible conditions the Ukraine and its inhabitants have to endure currently. Our heart is with you. Let's now start with the session, Clinical and Translational Pancreatology, What's New? And the first speaker will be Jonas Rosendahl from Halle. And I would be happy to hear his talk. Please play the first video.
Dear ladies and gentlemen, it's a great pleasure for me to get the opportunity to speak at this virtual EPC meeting. And I first of all want to congratulate Natalia and her team for making this event possible in this unbelievable situation. The topic of the current talk will be whether enzyme preparations of non-animal origin have pros and cons to be used in the daily clinical practice. I have some conflicts of interest to declare. I have advisory tasks for the Nordmark Pharma company and for Microtech, and I've given talks for the Falk Foundation and Viatris. But all these conflicts did not influence the talk I'm giving now. If we talk about pancreatic enzyme supplementation, we have to think about the ideal pancreatine. And most of us would agree that you would say you are what you eat. But if you take a deeper look at digestion, then you will see that the really truth is in the sentence that you are what you assimilate. And as such, pancreatic enzymes in the gastrointestinal tract are of utmost importance. So what would the ideal pancreatine look like? There are several aspects that should be addressed by the ideal pancreatine. One of all would be that it is active for all three components. As such, fat, protein, carbohydrates. Second, the efficacy of the ideal pancreatine should not be hampered by degradation or by gastric acid. And lastly, it should be comfortable for the patient. Of course, we should have an effective activity of the enzyme that resembles human physiology. So it should be available like the normal secretion under physiological conditions. Gastric emptying should be the same as when we have physiologic pancreatine secretion, and also the duration of enzyme activity, to just name some examples, should be comparable to the physiological situation. Digestion, of course, is a complex intervention, and you can see here that the main components, amylase, lipase, trypsin, are responsible for the degradation of what we eat, and this is realized in a very complex interplay between different aspects, one of them, for example, being the neuronal system. If you lose your pancreatine or do not have enough pancreatine to digest your food, then you can have several complications out of this. For example, if fat is not digested accordingly, then you will develop steatorrhea. For proteins, this will lead to azoturia, which is a rare condition, and carbohydrates not digested will lead to carbohydrate maldigestion, which is in addition a very rare complication. So if we have a perfect pancreatine to supplement if there is pancreatic exocrine insufficiency, these all components should be ideally recapitulated by the pancreatine that we administer. Another point is that it should not be hampered by gastric acid, and the efficacy should be the same as in the normal physiological condition. What you can see here is a very old publication that shows that in patients with pancreatitis, the duodenal pH is different and lower than compared to normal controls. You can see that the pH is around 4, and as we all have learned during our studies, this would irreversibly destruct lipase, and as such, lipase could no longer be available for the digestion of what we eat. The third point is that it should be comfortable to the patient, the ideal pancreatine. And this suggestion made in 1859 might not be the best way to get the enzymes into the digestive tract, as it was proposed that you just eat it like a sandwich, the veal pancreas, and thereby you can get the pancreatic enzymes into the place where they should work, and then finally you can substitute what is missing. So what do the recent guidelines say when we talk about pancreatic enzyme preparations? This is taken from the Han-Panoy guidelines published by Matthias Löhr, and you can see that the recommendation is that we use enteric-coated microspheres or mini microspheres with a diameter of less than 2 millimeters, and these are the preparations of choice regarding pancreatic exocrine insufficiency. Micro or mini tablets of 2.2 to 2.5 millimeter in size may also be effective, but as mentioned here, the scientific evidence in the context of chronic pancreatitis is limited in this regard. So is it really true that we just need the small microspheres, or might other spheres or diameters of the pancreatic enzymes also be good enough to have a proper digestion? This is a summary of what we know when you take the passage of the Polaris 50% in minutes in context of the sphere size, and you can see there are differences for sure between the different sizes of the pancreatine preparations, but maybe the clinical implication of these measurements are not so large, so that we have to rethink what really the size of the diameter of the microspheres might be to best resemble the situation that we have under physiologic conditions. And this is also stated by the guidelines that we lack clinical trials of different enzyme preparations, so-called head-to-head comparisons. And maybe we also need the right endpoints. One of the most important endpoints might be, but this is just a suggestion, the clinical efficacy of the products that we use in the patients. So what's the difference to non-animal versus animal-derived products? And what you can see here in the summary taken from a recent review on the topic is that the enzymatic activity of non-animal-derived pancreatines is much higher in comparison to animal-derived pancreatine. You can see, for example, the lipase units, which cannot be translated that easily, are higher in the non-animal forms, and the same holds true for amylase units and protease units. The question is whether we should then just use the non-animal fungal derived, for example, enzyme preparations in comparison to the animal derived pancreatine preparations. And what I can tell you now is that the studies that are available in this regard are scarce. So we have just a couple of data that can help us with the decision which one might be more suitable for the patient. So this is one of the studies published in 1989 in that 11 pancreatectomized dogs have been used. They got a fixed dietary intake of fat with fungal lipase, 400 milligrams, which corresponds to 4,800 units of lipase in comparison to pancreatine, 10 grams, which compares to 60,000 units of lipase. And what is shown in the graph here is the fecal fat content in 24 hours. And you can see in this presentation is that the difference between the fungal lipase and pancreatine from animals was not significant. So both enzyme preparations led to similar amounts of fecal fat concentrations in this scenario. Another point mentioned was the volume of stool in this study. And again, it seems that the fungal lipase is comparable to the animal-derived pancreatine displayed here. So there was no significant difference between the volumes of dogs that received the fungal lipase compared to pancreatine derived from the animal. In conclusion, it seems that small doses of the acid or more acid-stable fungal lipase seem to be comparable to high doses of porcine lipase, but we have to note for sure that this is just one small study made in animals, so we cannot translate this easily to the human situation. Unfortunately, there's not too much data regarding the human situation, at least published data available. Here, one study published in France and only available in French language compared fungal lipase versus classical porcine pancreatic extract as shown here. They've also performed some in vitro studies to test pH, biliary acids, colipase, trypsin, and albumin in these settings. And then they investigated 13 patients with severe pancreatic exocrine insufficiency. They all received a test meal, randomized crossover design. So it looks like a good study that has been done here, but the number of patients for sure is limited. The bioavailability was tested by double intubation method, which would be different or difficult to accomplish these days. So what's the result of this study? You can see that the in vivo percentage of lipase activity recovered in these patients was lower in the group that received the fungal lipase compared to the classical pancreatic preparation. We have 14.2% plus minus 10.6 versus 56 plus minus 50. So it seems that in this study, the animal-derived pancreatic enzymes were much more efficient than the fungal lipase. And the consequence was that the authors concluded that pH stability of the fungal non-animal derived enzymes might not be the only valuable factor that has to be taken into account. There might be others like proteolytic degradation of these enzymes or gastric emptying, which should be the same as in physiological conditions at its best. Another study, again, compared non-animal preparations against animal pancreatine in pancreatic exocrine insufficiency, and the therapeutic effectiveness was compared between pancreon granulate, then acid-protected porcine pancreatic enzyme preparations, and the acid-stable fungal enzyme preparation without any names of companies given here in this slide. 70 patients with chronic pancreatitis and pancreatic exocrine insufficiency, and it was measured the reduction in total fecal fat excretion per day. We have two groups here. We have one group of patients that has been operated and underwent the Whipple procedure, and you can see that the distinct doses that have been used here lead to different percentages of a reduction in total fecal fat excretion per day. So the acid-protected porcine pancreatic enzyme 58%, pancreon 67%, and the fungal ones 54%. In the non-operated group, the results were slightly different. Again, 58% for the acid-protected porcine pancreatic enzymes, 52% for pancreon, and 46% for the fungal enzyme preparation, and the doses that had been used were the same as stated above. So in this regard, the authors of this work concluded that in the operated patient, it seems that pancreon granulate is the most efficient pancreatic enzyme that can be used for these patients, whereas in the non-operated group of chronic pancreatitis patients, it seems that the acid-protected porcine pancreatic enzyme preparation is slightly better than the others. And if we take into account the differences, then we have to state that, again, it's a small study with a small number of patients, and the difference don't seem to be so huge, so that maybe the clinical outcome could be the same if you increase the doses, for example, for the fungal preparation. So what to conclude in regard of the question, what are the cons and what are the pros for fungal-derived pancreatic enzyme preparations? One of the advantages is that these preparations are acid stable, so you can see the activity from pH 2 to 10. So in conclusion, less lipase units are needed in this regard, but there seem to be other points that reduce the effectivity of the enzymes. They provide a broad spectrum of digestive enzymes. They are not dependent on animal breeding, and I don't want to go into details here, but it might be that in the future animal breeding will change, and maybe the availability of porcine-derived pancreatic enzymes will decrease. Maybe, and this is just really with a question mark, they have less environmental impact in comparison to animal-derived pancreatic enzymes. Disadvantages? We don't have enough data to really say, okay, in the human situation, these preparations can be used and will gain these same results as other preparations. They are inactivated by bile salts in addition, and there's degradation by proteases. So the final conclusion is that we need more studies to really show what is the best for the patient in this regard. Thank you very much for your attendance.
Thank you very much, Jonas. Okay, thank you very much, Jonas, for a nice overview on a quite interesting topic. As you said it, basically the differences are not really big. If you could probably address this all just by changing the doses or by increasing doses or by changing the preparations. Yeah. So why do you think that so little studies have been done with fungal pancreatine? The studies you showed all have some 20 or 30 years of age.
Yeah, it seems to be not the hottest topic at the moment on the market. Mm-hmm. Let's see what happens in the future. I would assume that things get more difficult with porcine derived pancreatic enzymes, as I hope and think there will be changes in the future how we make nutrition in the world. So maybe it will decrease and it will not be so easily available to get to the porcine pancreas. And if it works, I mean, the fungal derived products seem for me really like a good choice that have a good chance in the future to have a real role on the market. But I'm not into the market things of the companies.
So I'm getting requests from patients that are strong or strict vegetarians. When I tell them that they have to take porcine pancreatine, they say, "Oh, we are not going to take it." And that's the times when I switch to those fungal preparations, and they seem to work. And as you said, if it doesn't work, it's just a matter of increasing the dosage. So I'm wondering. Then you mentioned we need more clinical trials, and if we do them, we need good clinical endpoints. So clinical efficiency is one thing. But how would you measure that? Measuring the volume of stool and fat content is something that is not so happily or readily done in clinical trials nowadays. So what would be your endpoints?
Yeah, I think this is really difficult, and it was easy to write we should have the right endpoints without naming them.
Yes, I wanted to punish you for that.
Yes, because at least in the way we work, in our clinical practice, the most important thing is that the patient feels better, and then we have some nutritional markers like we look for vitamin D, A, E, K, and look if osteoporosis is developing. So I think this is what we do in real life. If this is sufficient for a study, I'm not sure. But on the other hand, I'm also not sure whether the real importance lies, for example, in the pylorus passage. If there's a difference from 50% to 60%, if this is really a hard clinical endpoint. It's good scientifically, but for the patient, I'm not too sure if this is the best way to analyze this.
Okay. There are no more questions in the chat. Please remember that you can send your questions to the speakers via the chat, and we will then ask the speakers for you. And I think we have to continue now. Jonas, thanks a lot for this interesting topic. And I just hand over to Patrick for introducing the next speaker.
Yeah, thanks, Thomas, and hello from my side as well. And it's my pleasure to welcome and introduce our incoming president, Heiko Witt, who actually I don't think needs further introduction. He's really a well-known expert on genetics in pancreatology and also on pediatric pancreatology. And he will give us a live update now on the very important pediatric aspects in pancreatology. Heiko, the stage is yours.
Thank you, Patrick, for this nice introduction, and also thank you to the Ukrainian colleagues for the kind invitation to talk here. As a bean counter, I have no conflict of interest. Unfortunately, I have no pharma company stocks or something like this. I want to talk about pediatric aspects of chronic pancreatitis. And if you look at the etiology, the main cause of pancreatitis, chronic pancreatitis in adults is severe alcohol consumption or abuse. And a small proportion is thought to have idiopathic pancreatitis, but idiopathic pancreatitis means maybe also inherited or genetic pancreatitis. And then a very small proportion is thought to have hereditary pancreatitis, dominant pancreatitis by, for example, trypsin mutations. Alcohol consumption does not play a role, at least in Europe. In the United States and Inspired might be something different. And what we see in the pediatric cohort is that genetic defects in trypsin mutations, other mutations, and the percentage of idiopathic pancreatitis is much, much higher in this age group. And also we have a significant percentage of anatomic anomalies, choledochal cysts. Cystic fibrosis is a very important topic. Yes, cystic fibrosis is a pediatric disease, and if you have at least one mild mutation, you are pancreatic sufficient. And 10 to 15% of the patients with cystic fibrosis without exocrine pancreatic insufficiency display recurrent attacks of pancreatitis, 1 to 2% of overall of the CF group. So cystic fibrosis is an important disease and important differential diagnosis in chronic pancreatitis. If we look at the data, and if we try to compare hereditary or idiopathic pancreatitis with alcoholic pancreatitis, these are data from Beat Mühlhaupt, Rudolf Ammann, then you can see that the probability of no calcifications in alcoholic pancreatitis is much, much lower compared to idiopathic or hereditary pancreatitis. So median years to calcifications are nearly the half, 6 years against 10 or 13 years. The same is also true for diabetes. Yes, in alcoholic pancreatitis, according to this study, yes, the median of the development of diabetes was 8 years. Yes, in hereditary idiopathic, very similar, because maybe idiopathic is in many cases also inherited. Yes, the median was 27 or 28 years. The same is also true if we look to exocrine insufficiency. Yes, it's 3 to 4-fold slower progress in idiopathic alcoholic pancreatitis, idiopathic and hereditary pancreatitis compared to alcoholic pancreatitis. If you look here, this is the alcoholic pancreatitis group here, the idiopathic and hereditary pancreatitis group. So, and the same data were also obtained years ago, 20 years ago, nearly by Volker Keim and me, that the probability of calcifications as well as of diabetes mellitus is much, much lower in idiopathic and hereditary pancreatitis. Hereditary means in this case patients with known and trypsinogen mutations, BRSS1 mutation, compared to alcoholic pancreatitis. And this is important if we talk about chronic pancreatitis in children, and if we talk about therapy or what else we want to do, because we cannot compare alcoholic pancreatitis with hereditary idiopathic pancreatitis. Both are inflammatory disease of the pancreas, yes, but in my view, these are different diseases. And so if we summarize data, then we have important differences between children and adolescents and adults. Yes, we have a much higher fraction of hereditary idiopathic, this means genetically predisposed pancreatitis, a higher frequency of cystic fibrosis or anatomic anomalies compared to adults where alcohol is the predominant cause. We have a much slower progression compared to alcoholic pancreatitis. We have a different clinical presentation. The pain is usually located epigastric, and patients suffer from recurrent attacks, not from chronic pain. There's more A-type pain, and there is rarely radiation of pain in the back in the first 10 years of life. And in contrast to adults, we have, with respect to surgery or endoscopy, no valid data. Even in adults, data could also be better. But all things we are doing in pediatrics is just to take adult data and say we can apply it to children. But I have serious doubt that it is right. And so also in the guidelines, in the pediatric guidelines, yeah, we take the data from adults, and maybe this is wrong. Another point is what do we know about pancreatitis in children? And there is a very extensive approach to understand pediatric pancreatitis by the INSPIRE group, yes. And however, I have some concerns. Nevertheless, it's a very important task they are doing. If you look at the data, it's cohorts divided into onset under 6 years, 6 to 11 years, and over 12 years, yes, then you can see that they diagnose patients under 6 years with alcoholic chronic pancreatitis. I think that's very unusual. Also, yes, they have patients under 6 years which are active smokers. That's hard to imagine. Moreover, passive smoking exposure is a reason of pancreatitis in children under 6 years is also difficult to imagine in my view. Yes. So the question is, can we trust this data, and how did they collect this data? And this is mainly a retrospective study. And also, it's frequently an approach to determine the weight of different genes or genetic mutations in pancreatitis. But if you look to the data of the INSPIRE study published 2017, yes, then you can see, yes, that there were 2 patients, one homozygous, one heterozygous for the CFTR M470V variant. Unfortunately, this makes a allele frequency of 0.6%. But these are data from Jonas Rosendahl published in Gut. Yes, that's a very common SNP. So nearly 50% of the individuals in the normal populations bear the SNP. So something can not be right with this genetic data. And there is an approach from Hungary, and maybe there should be also more efforts from the ESPEG and the European Society of Pediatric Gastroenterology and Nutrition to start with an European pediatric register, because I think we have to correct some data published from the United States. So if we talk about pediatric pancreatitis, I want to talk a little bit about genetics and unpublished data, which are in press since 3 days. So we have some models. We have the premature trypsin activation, reduced trypsin inhibition model, the trypsin center hypothesis by PSS1, SPINK1, CTRC mutations. We have the idea of ER stress, that ER stress by CPA1 and CEL mutation cause pancreatitis. We have the so-called ductal hypothesis, but this is critically, we propose that, for example, TRPV6 has ductal pathology, but also calcium sensing receptor, but calcium sensing receptor is not expressed in human ducts. Yes, it's expressed in the parotid gland, and moreover, TRPV6 is maybe not expressed in the ductal cells. There are recent data from a mouse study. They found TRPV6 expression only in acinar cells, not in ductal cells. This is in contrast to the GTEx data and the data or single cell data, for example, from Seger-Stolper et al. Maybe there are differences between humans and mice. Maybe the data, this is a very good study by Wartenberg and colleagues. Maybe we have to rethink that the pathogenesis of TRPV6 mutations is acinar, not ductal. And then we have several genes as lipase, CUTC, published recently, where we have no idea about the pathomechanism. And to come back to the very old model, the trypsin center hypothesis, there was recently described another protease, chymotrypsin, like elastase or elastase 3B. And this was an American study published 3 years ago by Moore and colleagues. And there was another study recently, last year, by the French group from Brest, that both studies describing mutations in codon 90 of the CELA3B, leading to increased trypsin or chymotrypsin activity. In the initial study, there was an impressive pedigree. However, only 2 patients were genetically analyzed, and in both patients, Moore and colleagues found a codon 90 variant arginine to cysteine at codon 90. This is conserved. All other human chymotrypsinogens have a leucine, not an arginine at this position. This is important because the French study found the arginine, not an arginine to cysteine, they found the arginine to leucine variant in their group. And the data they performed, the Moore and colleagues, were impressive, and they are indicating that there is a gain of function by this variant R90C and R90L. And they also performed mouse studies with impressive data that there is a increased fibrosis in the transgenic mice with R90C or L, that the 89 is a mouse homologue to 90. These are the French data. They found the R90L variant in 4 of 600 patients, but never in controls. We also performed a study. It's a German, Hungarian, Swedish, Polish love affair. And we analyzed German patients, 550 patients and more than 1,000 controls. And we found a splice site variant leading to a loss of function significantly enriched with an odds ratio of about 4 in our German discovery cohort. And we could also replicate this finding in the European cohort. Yes, there was a higher frequency in non-Germans, but the odds ratio was similar with 5.1. So this replication clearly indicates or highly suggests that a loss of function of CELA3B predisposed to chronic pancreatitis. And we did not find any codon 90 variant in nearly 1,000 patients. So this is in striking contrast to the reports of Moore et al. And Emmanuel Masson et al., who presumed a gain of function. If we look at the trypsin center model, then we have to state that CELA3B might be a risk gene, but unfortunately not by gain of protease activity. It belongs to the group of unknown mechanisms such as lipase, CUTC1, or TRPV6. A lot of collaborators I want to thank, especially Esther Hegi and the Hungarian colleagues, also Matthias Löhr, Gregor Orac and Agnieszka Riegel, and also Miklos Schein-Todt, who performs the functional analysis of the CELAS 3B variants. That's not complete, this list. I have to thank many, many other people too. And this is the most important slide of my talk. Yes, the next EPC meeting will be in Alpbach, Tyrol from June 28 to July 1st in collaboration with the Japan Pancreas Society, GPS. I thank you for your attention.
Thanks, Heiko. Very intriguing, very interesting talk. And I really encourage also the audience to put their questions in the chat. I don't see any questions right now, but I still start. So I think I learned from Jonas in his talks as well, and from yours as well. There's always this balance in adulthood between metabolic, exogenous factors and genetics. And I think you really elucidated these accumulating data on genetic disease. On the other hand, we have the obesity problem also in the pediatric population in Europe and in the United States. Are there any data how the incidence and severity of recurrent or chronic pancreatitis in the pediatric population has changed?
There are data that obesity is rising. There are data that acute and chronic pancreatitis is rising, but there are no data, to my knowledge, showing a correlation. Maybe nobody investigated this really good.
Okay. And you mentioned in the beginning, you mentioned still 40 to 50% get the stamp idiopathic, and we all think it's genetic or of NGS on whole exome sequencing. What do you think? How many idiopathic cases will remain in 10 years?
This question is pain in the ass. I think a lot will remain. Yes, the low-hanging fruits, we have them with SPINK1, with carboxypeptidase. And the future will be as lipase, as could be, we will have 1 to 2% or 0.5% genes. That means we find mutations in 0.5 to 2% of patients enriched, and this to prove is extremely difficult. And what we see by preliminary data is that there will come new genes in the next 2 years. Yeah, several new genes, but there's no SPINK or even TRP36, which is more common. Yes, and it's extremely difficult to prove. You have to make functional data to prove it.
There's one question from the chat, actually from my co-chair, moving to the anatomic cases in pediatrics. What type of abnormalities, which we see also in adulthood, of course, do you see in your clinical experience?
For example, choledochal cysts. Yes, and we don't have, for example, rarely sometimes in the adolescents, annular pancreas, but usually the main presentation of annular pancreas in pediatrics is neonatal ileus, yes, obstruction, intestinal obstruction, and okay, and pancreas divisum, it's an old debate. What shall we think about it? But, yeah, but it's mainly choledochal cysts.
Okay. But I mean, in adulthood, I think if we talk about anatomic abnormalities, it's mainly the debatable thing of pancreas divisum, which we are faced with. We don't see so many choledochal cysts. Well, as a first hint. Okay. Okay, I think we have to move on. Thanks a lot, Heiko.
Okay.
We're looking forward to the Alpine Village next year. And I hand over to Thomas again.
So thank you, Patrick. I have now the pleasure to introduce Enrique Dominguez Munoz from Santiago de Compostela. I think it's hardly necessary to introduce him. There's Very few people have done such a lot of work in pancreatic function, chronic pancreatitis, endoscopic ultrasound, and him and has well published them. He may not remember, but he and I were for 1 or 2 years at the same institute when we were young. That is a long time ago. And now he has a interesting talk with the title Laboratory Diagnostics of Pancreatic Diseases and Functional Test. The King is Dead or Long Live the King. It's an impressive title. Can I have the video?
Hello, and first I would like to thank the organizing committee for inviting me to this meeting to talk about laboratory and functional diagnosis of pancreatic diseases. So, you know, some decades ago, about the 60s, the functional diagnosis of pancreatic disease was the king. And the reason for that was that the accuracy of imaging techniques was not as high as it is today. And over the following decades, several pancreatic function tests were developed, tests based on the exogenous stimulation or endogenous stimulation of pancreatic secretion, tests evaluating the secretory or the digestive capacity of the gland, and measuring some markers or substrate in different fluids like stool, blood, duodenal juice, urine, or breath. We can summarize the tests that we have available or that we had available in the past in that slide. And basically, we have circulating biomarkers that we use every day in our clinical practice for the diagnosis of pancreatic diseases or the etiology of pancreatic diseases, and pancreatic function tests, both exocrine and endocrine. And today, for the aim of this presentation, I will focus on the exocrine pancreatic function test. Look, we have direct test. That means that test based on the quantification of pancreatic enzymes and bicarbonate in duodenal juice. We have indirect test, in which we evaluate the result of the digestion mediated by pancreatic enzymes in the gut, and fecal test, basically fecal fat, the coefficient of fat absorption, and fecal elastase. The question is, what is the potential use of this function test in clinical practice? Of course, we can use them for the diagnosis of chronic pancreatitis. We can use them for the diagnosis of pancreatic origin of digestive symptoms, mainly chronic diarrhea. And of course, for the diagnosis of pancreatic exocrine insufficiency and the evaluation of the efficacy of pancreatic enzyme replacement therapy. Let me start by talking about the diagnosis of chronic pancreatitis. In that setting, the most accurate tests are the direct test. Direct test means to quantify pancreatic secretion output of pancreatic enzymes and bicarbonate after exogenous stimulation of pancreatic secretion by intravenous administration of secretin and CCK, or endogenous stimulation by giving a test meal, collecting duodenal fluid samples in different aliquots and quantifying the output of enzymes and bicarbonate. In that case, using this test, we can define pancreatic secretion as normal, mild, moderate, or severely reduced. These tests are no longer used in clinical practice. You can still use it for research, and this has been substituted by the endoscopic pancreatic function test after secretin stimulation. In that case, what we do is during endoscopy to collect samples of duodenal juice stimulated by intravenous secretin to quantify the concentration of pancreatic bicarbonate. This test appears to be really accurate. And in one of the first studies, as you can see here, the bicarbonate peak, concentration peak, is clearly abnormal in patients with chronic pancreatitis, is clearly normal in patients with chronic abdominal pain with no risk of chronic pancreatitis, and as you can see, is abnormal in patients without clear morphological signs of chronic pancreatitis, but chronic abdominal pain with risk factors of the disease. So it seems to be a quite accurate test for the diagnosis of early changes of chronic pancreatitis. That has been supported later in another study, very nice study, including more than 250 patients with suspected minimal change of chronic pancreatitis, together with endoscopic ultrasound. And as you can see, usually in red and green, both tests, endoscopic ultrasound and endoscopic pancreatic function test, provide concordant result. But this is not always the case. And there is a group of patients, very interesting, in that study, 40 patients with normal endoscopic ultrasound. Remember, we are talking about patients with suspected minimal change chronic pancreatitis, normal endoscopic ultrasound, but abnormal endoscopic pancreatic function test, meaning that it could be that the endoscopic pancreatic function test is even more sensitive than endoscopic ultrasound to detect mild changes of chronic pancreatitis. Well, currently, this endoscopic pancreatic function test is frequently used in the context of the endoscopic ultrasound evaluation of the pancreas, together with the dynamic evaluation of the main pancreatic duct after secreting injection, evaluating the degree of fibrosis by elastography, and of course, the V-mode endoscopic ultrasound in the so-called multimodal EOS-based evaluation of the pancreas for early chronic pancreatitis. The second potential clinical use is the diagnosis of pancreatic origin of digestive symptoms. I'm talking mainly about chronic diarrhea. You know that if we have a patient with chronic diarrhea, if we suspect an organic disease and the patient is telling us about weight loss, fatty diarrhea, or risk factors of pancreatic disease, it makes sense to use a pancreatic function test, for example, fecal elastase, as a screening test to support the pancreatic origin of diarrhea or to exclude it. You know about fecal elastase. Fecal elastase is a pancreatic specific enzyme. It's stable during the GI transit bound to bile salts. The fecal concentration that we can evaluate correlates significantly with pancreatic enzyme secretion. It is stable. The enzyme is stable in that sample, even at room temperature. And as you know, the interruption of pancreatic enzyme replacement therapy is not required for that test. Putting all these features together tell us that the fecal elastase is a very simple test. It is widely available and is for sure the most widely used pancreatic function test in clinical practice. How this test behaves in the context of chronic diarrhea in order to establish the pancreatic origin of that diarrhea. There are several studies on that. This is one of them, very nice study, including more than 200 patients with chronic diarrhea and using fecal elastase to discriminate between pancreatic and non-pancreatic origin of the diarrhea. Look, if fecal elastase in this context is normal, we can exclude the pancreatic origin of diarrhea. The negative predictive value is very high. However, if fecal elastase is low, we cannot confirm the pancreatic origin of diarrhea because the positive predictive value is quite low. And finally, of course, we can use pancreatic function tests to diagnose PI or to evaluate the efficacy of pancreatic enzyme replacement therapy. What are we talking about? Recently, PEI has been defined as a reduction of pancreatic exocrine activity in the intestine at a level that prevents normal digestion. I like to define it as a failure of the exocrine pancreas to deliver in any situation the required amount of enzymes to the intestinal lumen for a normal digestion of the ingested food. That means we are talking about digestion, and there are many factors influencing the concept of pancreatic exocrine insufficiency. So pancreatic secretion is just one of these factors, but there are many others involved in this context, like intestinal pH, anatomy, function, dietary habits of the patient, the nutritional needs, and the disease-causing PI. If you understand that, it is easy to understand that pancreatic function test based on the quantification of pancreatic secretion, not digestion, are not good tests for the diagnosis of pancreatic exocrine insufficiency. The gold standard of digestion test is the coefficient of fat absorption. It is also the gold standard according to the FDA or the EMA to evaluate the efficacy of pancreatic enzyme replacement therapy. But this test is not an easy test. It's very cumbersome. And you can see that the patient should keep on a diet containing 100 grams of fat per day over 5 days, and they should collect the total amount of feces produced over the last 3 days of this 5-day period. And at the end, the handling of the feces in the lab is rather unpleasant. So it is the gold standard according to the medicine agencies, but it is not an easy test to apply in clinical practice. Because of that, over the last many years, decades, several indirect pancreatic function tests has been developed. What is the concept? is to evaluate the digestive activity of a pancreatic specific enzyme in the gut by using a specific substrate together with a test meal. And here you can see the pancreatology test or the PAVA test evaluating the activity of pancreatic cholesterol ester hydrolase or chymotrypsin, and evaluating the product of that digestion either in blood or in urine. There is a more recent pancreatic function test because the pancreatology test and the PAVA test are not longer commercially available in the majority of the countries. There is a more recent test, which is the malabsorption blood test, evaluating in the same way the activity, digestive activity of pancreatic lipase and taking blood sample over 8 hours. Probably the most appropriate test to evaluate fat digestion is the C13-MTG breath test. The idea is to provide orally C13-MTG, which is a triglyceride, together with a test meal. The substrate will be digested in the gut specifically by pancreatic lipase. The result of the digestion will be absorbed, metabolized in the liver. C13O2 is released and exhaled in the breath. So we can quantify how much substrate was digested by quantifying the delivery or the recovery rate of certain CO2 in the breath. This is a very accurate test compared to CFA for fat maldigestion, but the most important advantage of the breath test is that the breath test is not a number like CFA. The breath test is a dynamic curve of the digestive process of each individual patient, as you can see in this slide. In that case, the breath test is also a very good test to evaluate the efficacy of pancreatic enzyme replacement therapy, as you can see in this slide. Look, on your right, you see this is an individual patient. It was a patient after pancreatic duodenectomy, before therapy in red, after pancreatic enzyme replacement therapy in blue. So it's very nice, you can see, to evaluate by the breath test the efficacy of pancreatic enzyme replacement therapy. Compared to the titration of the enzyme dose based on clinical relief, symptom relief, the titration of the enzyme dose based on the normalization of the breath test is associated with a better increase of body weight and better nutritional status significantly. And we can use fecal elastase for the diagnosis of pancreatic exocrine insufficiency. And these are the studies that have evaluated the accuracy of fecal elastase compared to CFA as the reference method. And the mean accuracy is a sensitivity of 85%, specificity of 64%. Taking this accuracy into account and taking into account the pre-test probability of PI according to the pancreatic disease leading to PEI, we can calculate the positive predictive value of a low fecal elastase or the negative predictive value for PI of a normal fecal elastase. Look, if we focus in patients with a high pre-test probability of PI, for example, patients with a tumor in the head of the pancreas, with a cancer in the head of the pancreas, a low fecal elastase has a very high positive predictive value, helping us to support the presence of PI, but a normal fecal elastase does not allow us to exclude PI because the negative predictive value is very low, between 30 to 50%. On the contrary, patients with a low pre-test probability of PI, for example, chronic non-calcific pancreatitis, a normal fecal elastase allows us to exclude pancreatic exocrine insufficiency because the negative predictive value is very high. However, a low fecal elastase does not allow us to support the presence of PI because the positive predictive value is very low, between 20 to 50%. So, in summary, what tests are still alive and what for? In my opinion, the endoscopic pancreatic function test is alive. In the context of the diagnosis of early chronic pancreatitis, is still in the area of clinical research. Of course, fecal elastase to screen patients with chronic diarrhea, to support or exclude the pancreatic origin of chronic diarrhea, and to support or exclude pancreatic exocrine insufficiency in patients with pancreatic disease according to the pre-test probability of pancreatic exocrine insufficiency. And finally, the C13-MTG breath test for the diagnosis of PI and the evaluation of the efficacy of pancreatic enzyme replacement therapy. Breath test is not widely available, still in the context of clinical research, but a very nice test for this aim. So this is my last slide. I would say the king is dead or almost dead for the diagnosis of pancreatic diseases, although still I keep a door open or a window open for the endoscopic pancreatic function test. And long live the king in the context of evaluation of the impact of pancreatic diseases on pancreatic function, to diagnose pancreatic exocrine insufficiency, and to evaluate the efficacy of pancreatic enzyme replacement therapy in patients with pancreatic exocrine insufficiency. Thank you very much for your attention.
Thank you very much, Enrique. So the king is not dead. Okay. What would you say, a standard gastroenterologist, pancreatologist, what tests should he have available?
Well, you know that the only test really available for clinical practice is the fecal elastase. We don't have any other. The important is to understand what is the meaning of the result that you get of fecal elastase. There is a lot of confusion on that. People with a false positive fecal elastase being referred to a pancreatic unit just because fecal elastase is low with a fully normal pancreas, or vice versa. So fecal elastase provides it can provide nothing else. And this is a test telling you with a lot of confounding factors about the secretion of pancreatic enzymes. But you need to understand that there is a lot of false positive results. So that's why I told you about the pretest probability of PI. If the pretest probability of PI is very low, forget a low fecal elastase.
But that's a very good point. And what do you do then when you have such a probably wrong fecal elastase value to confirm that it's not chronic pancreatitis?
Well, it is really hard, and we need to take into account also the patient sitting in front of us. And frequently we need to have a look to the pancreas because the patient is worried about a pancreatic disease due to that result. So even in the absence of any risk factors, even in the absence even of clinical signs of pancreatic disease, sometimes we need to have a look to the pancreas whatsoever, depending on the patient, either MRI or endoscopic ultrasound. That's the real life.
Okay, there are some questions now in the chat from Gabriele Capuzzo. It says, great talk, Enrique. In a pragmatic way, it makes poor sense to test pancreatic function when pretest probability is very high. Just treat.
This is what we do in clinical practice, actually. I mean, if you have someone with a pancreatic cancer in the head of the pancreas, clearly obstructing the main pancreatic duct, a duct dilated, I mean, we don't need any test because the pretest probability is already very high. So we can start with the therapy immediately. We don't need to lose time to start the therapy. So if the pretest probability is very high, we don't need any test, actually.
Okay. From Heiko, we have fecal chymotrypsin. Do you use it, or when do you use it?
Okay, we don't. Fecal chymotrypsin was a test that we use a lot before fecal elastase. The problem is that the chymotrypsin is inactivated along the oral transit time, so partly inactivated. So what we can still use fecal elastase as a test to evaluate the compliance to therapy, because to pancreatic enzyme replacement therapy, because evaluating fecal chymotrypsin, you are also evaluating chymotrypsin for pancreatic extracts from exogenous pancreatine. So this is a test that we can still use to evaluate the compliance to therapy.
Okay. Joanna Alfonso asked you whether you ever use fecal elastase to follow up your patients.
Well, I mean, we do. I don't know why, but we do. Because it is one of the tests that we use, I mean, together with the nutritional markers. But you know, there is a inter-day variability in the same patient, intra-individual variability of fecal elastase. If you measure fecal elastase 1 week apart several times, you will see that there is a variability. If you do it every year, that variability also exists. So you cannot say that because fecal elastase is a bit higher, you cannot say that the pancreas is doing better, or vice versa. So not really a good test, I must tell you, for that.
Okay. Let's talk now about clinical trials. We talked with Jonas about what are the right endpoints when doing clinical trials for pancreatic insufficiency or chronic pancreatitis. And we need clinical trials in pancreatology. So what would you suggest now that you have done an overview of function tests?
Well, first of all, if you want to quantify digestion, independently of FDA or EMA, if you want to quantify digestion as endpoint, the breath test is a perfect test. You can repeat it frequently, and it is very easy for patients and for people working in the lab. But Jonas told it very well, in a sense that from a clinical point of view, important are symptom relief and impact on the nutritional markers, on the nutritional status. And probably this could be the real endpoints for clinical trials.
Okay. So there are no more questions from the chat. It was a pleasure, Enrique, to have a chat and a discussion with you, but we now have to move on. Thanks a lot. And we will now continue with the talk of David Whitcomb. It's a pleasure for me to introduce him. I've known him for quite a long time, and he has made really milestone contributions to pancreatology. And the first milestone, of course, the genetics of hereditary pancreatitis. So it's really a pleasure to have him here and to talk about latest evidence-based research in pancreatology, what's new. So can we have the video of David Whitcomb?
Good afternoon. I'm Professor David Whitcomb, and I've been asked to give the latest evidence-based research updates in pancreatology, and I thank my colleagues Vikesh Singh and Dheeraj Yadav for helping. I'm using this mechanistic model, which talks about the progression from normal to end-stage pancreatitis in order to break up the talk. I'll start on acute pancreatitis risk. What we see, first of all, is that there's an increase in the episodes of acute pancreatitis across the world and has been increasing at a rate of about 3% per year. The cost is also rising. This diagram shows the time from 1996 to 2016, and the expenditure has doubled to over $7.7 billion for treatment of pancreatitis. In the treatment of acute pancreatitis, there are some advances. The first thing is recognizing some of the risk factors, and this is a study by Roger Little's group from Duke University in animal models of acute pancreatitis. And he showed if there is a low phosphate diet, they end up with a lot of acinar cell damage due to low ATP, failure to clear calcium, and activation of trypsin. And this is reversed by adding sodium phosphate to the diet. There's another interesting study that shows that skeletal muscle density, or sarcopenia, is associated with patient mortality from acute pancreatitis with an odds ratio of 3.36, which I thought was quite remarkable. It's associated with persistent organ failure, percutaneous drainage, and need for ICU and length of stay. So sarcopenia turns out to be quite important. In hypertriglyceridemic acute pancreatitis, the biggest factors is that nobody is recognizing it. It turns out in a hypertriglyceridemia clinic, the patients that were admitted with acute pancreatitis, only a third of them, it was even recognized as being a problem in these patients. There's also a paper from Dallas, Texas, that showed that of patients that did have hypertriglyceridemia, only 50% of them were set for a follow-up, and only 18% had a follow-up triglyceride level. This is an area where we can make a huge improvement. Another important observation was that the risk of a bad outcome was not associated with BMI or visceral fat as predicted, but it was associated with low serum albumin, high CRP, and high lipase. The low serum albumin we showed in a paper by Comera as the first author. It's associated with a vascular leak syndrome because of toxicity to the endothelial cells, causing a loss of albumin by transudation. High lipase is also very important, as I'll show on the next slide. This first study is a very important one from Vijay Singh's group. He showed that hypertriglyceridemia hypertriglyceridemic acute pancreatitis is associated with fatty acid release by pancreatic lipase, and specifically its release of unsaturated fatty acids that are normally considered non-inflammatory, but they're highly toxic, especially to mitochondria. And it is the pancreatic lipase, not the high triglycerides, that is critical in driving this process. Another important paper was published that showed that there's a lot of damage caused by hypertriglyceridemic acute pancreatitis, and we know that there's a bad outcome. But interestingly, there's an intracellular signal that is driven by insulin that markedly improves the tolerance of these triglycerides and improves outcome. So insulin is critically important as an early treatment in hypertriglyceridemic acute pancreatitis. This is a study that is new data presented at DDW. This is from the Spanish group with Enrique El Madria, and he offered me these slides. What they did is a randomized controlled trial to look at aggressive versus moderate fluid resuscitation in the people with acute pancreatitis, and they compared these two protocols with careful checks at 3 hours, 12 hours, 24 hours, 48 and 72 hours. And this was multiple sites in Spain and 2 international sites. What they found was that there was a much greater fluid overload in patients with more aggressive therapy. The imaging suggested that there was more fluid sequestration. The patients with the more aggressive resuscitation had more dyspnea, more signs of failure, and actually were classified as moderate to severe, which neared significance. Because of this, this was terminated, suggesting that a moderate goal-directed therapy is much safer than a more aggressive fluid therapy. I think this is a very important study. For recurrent acute pancreatitis, fortunately, the idiopathic group is disappearing as we do more studies. The first study I'd like to point to, though, is a study in animals by Mikkel Sahun-Tooth's group. And what he showed is that the animals that were given one episode of acute pancreatitis were both sensitive and had more severe subsequent attacks. And he showed that this was caused by infiltrating macrophages. So this is the mechanism for the SAPE, or sentinel acute pancreatitis event. One of the challenges is a paper that was a letter by the UCLA group and others that did a randomized double-blinded placebo-controlled trial of simvastatin, one of the statins, to prevent recurrent acute pancreatitis, because it has been suggested in epidemiology studies that this may be an effective way of reducing recurrence. However, they found it a very difficult study to enroll patients into. Only 20% were actually enrolled, and the study was terminated because of a failure to reach the recruitment goals. So this summer in July at Pancreas Fest, the NIH is having a satellite workshop on how to organize and do clinical trials so we can do a better job of that. And since the dollar to euro equation favors the euro, you're all welcome to come to the United States cheap. Now I'd like to look at pancreatic genetics just briefly. This is a Mendelian randomization study that was done, and what it showed that for the genetic risk of gallstones and hypertriglyceridemia was associated with a risk of pancreatitis, as well as a genetic risk for tobacco use disorder and type 2 diabetes. So we'll talk about type 2 diabetes, but it looks like this is a risk for acute pancreatitis. In chronic pancreatitis, it's also interesting that calcium, genetic risk for higher serum calcium, is associated with progression to chronic pancreatitis, as well as triglycerides. Smoking, again, is a risk factor for chronic pancreatitis, but now alcohol, which is not a risk factor for acute pancreatitis, has a genetic predisposition for alcohol use in chronic pancreatitis. In exocrine pancreatic insufficiency, this is an area we need a lot more work. We know that there's no mechanistic definition, there's poor adherence to guidelines, and we do a clinical diagnosis made by physicians. These two papers show that nobody or very few people adhere to the European guidelines, and an international survey of experts done by the Dutch group showed that it's the Wild West, as we say in the United States, where everybody seems to have their own way of doing this, and there's no consistency. There's an important paper on the nutrition in chronic pancreatitis from the group in the United Kingdom that's worth putting in your files. And also a couple of papers are emerging on the importance of sarcopenia in patients with chronic pancreatitis and bad outcome. For diabetes mellitus, there's a very interesting paper that came from Max Petroff's group in New Zealand, and they looked at 152 patients without diabetes at the time of acute pancreatitis. And what they found was at 12 months, about 20% had diabetes, and at 24 months, it was up to almost 40%. This matches what we see in hereditary pancreatitis. What was interesting is when they looked at the risk factors, the only thing they could find was waist circumference was associated with a mild elevated in glucose, but it wasn't associated with this marked rise. We point back to a paper that our group published with the North American Pancreatitis Study, led by myself and Mark Goodarzi, showing that the type 2 diabetes risk genes are the ones associated with the marked increase in diabetes after an episode of acute pancreatitis, which seems to trigger the process. Moving on to pathogenic pain syndromes, which is a huge problem in chronic pancreatitis. There's a number of things that have happened. First of all, there is a new tool called the COMPAT short form, and I encourage everyone to use this to quantify pain. Secondly, it's interesting that in a big meta-analysis, about 12% of chronic pancreatitis patients have no pain at all, and this is regardless of the etiology. So the reason they have no pain is unknown. The natural course and burnout of pain turns out to not be very common at all in the United States. In the North American Pancreatitis Study, there was limited pain burnout, and it was especially low in patients with an alcohol etiology or they had chronic pain, especially those that had been gone through multiple interventions. The quantitative sensory testing is a new tool to try to sort out the mechanisms of pain and how much of it's central and how much of it is local, and are there other pain syndromes. So this was a study that came from my group, and we looked at patients with constant pain that was severe versus mild, and did a nested GWAS. And we found that there was a number of areas that had some level of association with severe pain. And when we looked at these areas, we saw that they were filled with genes associated with psychiatric stress disorders, such as major depressive disorder, general anxiety disorder, and PTSD. There was also a study done by the Danish group with Hopkins and Pittsburgh. And what they did is they looked at the patients who had QST, and also looked at questionnaires, patient recorded outcomes, and their CAT scans. And there was a few percent that had duct obstruction, but it was much more common that they had anxiety, depression, or catastrophizing. And as you add these factors together, you have a progressive and significant increase in pain severity, pain interference, and a low quality of life. So major depression, general anxiety disorder, and these factors turn out to be extremely important in pain experience. And these are targetable by identifying these genetic loci and which medications are useful in targeting them. In pain treatment, cognitive behavioral therapy has been tested. It looks like there's at least a 30% improvement in quality of life in patients that do an internet-based cognitive behavioral therapy, with 50% responding versus 13%. A pregabalin plus antioxidant was done in a placebo-controlled, double-blinded randomized trial, and showed that there was a reduction in pain and opiate use and hospitalization, but it was 18 versus 11% in placebo. So there was a clear improvement, but it was in a minority of patients. This is an important study that was in low back pain, and it showed that in acute injury and inflammation, if you treat with NSAIDs, the patients develop chronic pain. And they showed in animal studies as well that transient neutrophil-driven upregulation of the inflammatory response protects against chronic pain. So it wasn't the case in other types of treatments such as opiates, but non-steroidals seemed to change acute pain into chronic pain. And finally, I wanted to make a comment about the ESCAPE study, where it showed that early surgery was better than endoscopic in general. But if you look at the supplemental information on the left, you'll see that in blue, early surgery reduces pain more than endoscopic first. But if you subdivide the endoscopic first into those with duct clearance, shown in green, versus those that did not clear the duct of stones, you see that duct clearance was equivalent to early surgery and therefore still plays a major role. Thank you for your attention. And if there's any questions, I will try to answer them after the session, and you can contact me at whitcomb@pancreas.org.
Okay, thanks a lot, David, for this wonderful talk. David is present in the audience?
Yes.
Oh, okay. I found it intriguing what you mentioned about the NSAIDs and changing acute pain to chronic pain, but that was only for back pain, right?
Yes, it's only for back pain, but pain is a central nervous system problem, not an organ-specific problem. And what we're able to see is there are many components of pain that overlap, such as anxiety, depression, those types of things. They're not pancreas-specific problems, but they sure make the experience of pancreatic pain worse. And the same principles of the interaction between the immune system and the nervous system in the back may also have an implication in pancreatic pain. And I think that's an important observation and worth looking at in the future.
Okay, there's one question from Juliane Glaubitz in the chat. She asks whether hypercholesterolemia is not the direct etiology of acute pancreatitis like triglyceride, but can hypercholesterolemia be at least a risk factor or indirect etiology of acute pancreatitis?
I don't know the answer to that, but I do know that hypertension seems to be associated with chronic pancreatitis in the UK Biobank that was just published in January of this year. There are some overlapping pathologic features of risk for gallstones and hypertriglyceridemia as well. So there may be a indirect connection from there, but I don't think that hypercholesterolemia itself has been shown to be a major risk factor.
Okay, I found it very intriguing that you will have this workshop on how to do proper clinical trials in pancreatology. And I think you're right to do this. When you do editorial work for journals, you see that our clinical trials in pancreatology are usually not very good. Some exceptions, of course. So why would you think this is so? Many people have learned to do clinical trials. Is it the lack of good endpoints? Is it the complexity of disease, or why are we so struggling here?
So I think there's a couple problems, and it's really going to be fleshed out at this workshop. The first one is trying to find reagent grade patients. They don't come in as frequently as possible. You see the same severe patients over and over again. The ones that are doing well, you don't see coming back as often. So I think multi-center studies are important. Secondly, getting useful endpoints are helpful, and I think that we're getting better at that. The third thing is that what the FDA is looking for approval of new drugs is different than what the academics like for mechanistic insights And so trying to coordinate ideas with the FDA and with the academics is important, and the FDA is going to be a major participant in this workshop. An example that was mentioned earlier is that the FDA requires this 5-day fecal fat study for EPI, and so we have been discussing with them that that's really a ridiculous endpoint, and that those things need to be readdressed. So, there's going to be some major changes. The third and last point is that doing clinical trials are very expensive, and trying to get funding, adequate funding for these is important. I think the issue of patient burden is very important as well. The study for simvastatin that was done by the California group, nobody wanted to be in the study because it was so intensive, and they had to take time off work and travel and spend a lot of time getting multiple endocrine pancreatic function tests and the endoscopic test, and it was just, the burden was so high and the reimbursement for it was not worthwhile, and they just couldn't get anybody to join the study. So there are issues of a burden to the patient, taking time off, endpoints that are acceptable both to academics and the FDA. Can it be done remotely? Can it be done with lower impact on the patient? Can it be done at a lower cost? Can we be more efficient in classifying the patients by mechanism instead of by symptoms? Those are the things that we're going to be discussing. And I think that all of the parties are interested in getting this right, or at least better. So I think that'll help make better trials and get them finished.
Extremely important. I think we should get this news about this workshop more spread so that many other people attend if they can. I think that I liked as well in your presentation was that the topic of psychiatric diseases and pain. So what is your approach then? This seems really convincing that the depression, psychiatric conditions, it's not secondary, but rather a cause of pain. So what is your approach to identify those patients?
So we're working on developing a better approach. There are a couple of issues. The first one is that clinicians often don't ask probing questions to understand if this is a problem with the patient. Secondly is that the patients are sometimes, saying, I'm not depressed, I'm in pain. And so, using a combination of, some of these scores like the Promise 29, which has a number of domains already built into it. There's, 4 questions on depression and 4 on anxiety and pain, quantitative pain testing. So bringing that to the patient's attentions to help them manage the pain is important. It doesn't make the pain, these disorders don't make the pain severity worse, they make the pain experience worse. And that is an important part of the quality of life, is just how they deal with it. It's also important because it helps them understand their disease, just recognizing that those feelings they have may be genetically driven. They're targetable because we know that there's something that is similar in the pain management pathway and the depression pathway. And so sometimes you can find patients that don't really have depression per se, but antidepressants helps reduce the severity of the pain experience. So I think this is a lot of hypothesis generating, and we're trying to sort out the different components so that we can do an adequate clinical trial.
Okay, so we're back to the clinical trials. Well, thanks a lot. There are many more questions which we could have, because it is a wonderful overview, the most complete I've had for a long time. But I think we have to move over. There are no more questions in the chat. Thanks a lot, David. It was a wonderful.
Well, thank you for having me, and we look forward to a face-to-face meeting in the future.
Okay, thanks a lot. See you then. I'll hand over to Patrick Michel for the next talk and for closing the session thereafter.
Yeah, thanks, Thomas. And it's my pleasure to announce the last scientific speaker of this wonderful meeting, Julio Iglesias Garcia from Santiago de Compostela in Spain. I think well known to most of you as excellent pancreatic endoscopist, will cover a clinically highly relevant topic, in my view, on pancreatic endoscopic ultrasound in pancreatology. And we are looking forward to hearing his recorded talk first.
Okay, first of all, I would like to thank the EPC for the kind invitation for being part of this event. Unfortunately, we're not in Kyiv, and I want to give a big huge to the Ukraine population for the situation, and we are there with you. But secondly, I would like to give me the opportunity to talk about endoscopic ultrasound on the pancreas and on clinical and translational pancreatology and what's new, because it's for me one of the most important topics, and I've been dedicating most of my time to this combination of AUS and pancreas. So these are my personal profile. These are my financial disclosures regarding this lecture. But first of all, before even starting, I want you to know what is the combination of AUS and the pancreas, because it's very important to know that AUS was initially developed for optimizing the visualization of the pancreas. And the first ever publication was from CIVAC in 1986 with the title Endoscopic Ultrasonography for the Differential Diagnosis of Pancreatic Diseases. So this is the beginning, and AUS has really made a change in the management of pancreatic diseases. But this is also related for the huge development of AUS over the years. Just to realize that if AUS started in 1986, this was when Maradona scored the goal with the hand in the world champion. Today this is going to be impossible with the use of the bar, for those of you with interest in football. And look at the development that now, 2021, we have reached Mars. So this is also the evolution of AUS in scopes, in ultrasound systems, but also in the devices that we have available. Because we all know that AUS is absolutely linked to the pancreas in the four main diseases that we are going to cover. We know the key role in acute pancreatitis, absolutely essential for the management and diagnosis of chronic pancreatitis. It's absolutely changed the world in pancreatic tumors, in both solid and cystic pancreatic tumors. But before trying to go into what's new, I think it's very important to state what we know about AUS and pancreatic diseases. So I think we will all agree that AUS is the most sensitive method for the detection of microlithiasis, thus for the etiological evaluation of acute pancreatitis, and this is key, and we have included AUS in the etiological diagnostic algorithm of undetermined patients of acute pancreatitis, is key in the endoscopic step-up approach for the treatment of walled-off necrosis, and is playing today a key role in this setting. We know that is the most sensitive imaging technique for the diagnosis of chronic pancreatitis, mostly in early and moderate stages, in non-calcific chronic pancreatitis. Is the most accurate tool by far for the detection of solid pancreatic tumors, mostly for small solid pancreatic tumors, and today is considered as the most accurate method in the evaluation of worrisome features and high-risk stigmata when we are managing cystic pancreatic lesions. So now let's try to focus on what's really new over the last couple of years in the combination of AUS and pancreas. So let me start by highlighting the key role in the diagnosis of chronic pancreatitis. We know, according to the guidelines, that AUS is the most accurate technique for the detection of chronic pancreatitis, and this is published in 2017. But probably for me, the most important part is the role that we are playing in the detection of early chronic pancreatitis. Now we have developed the multimodal AUS-based approach, which is a AUS-based study in which we can evaluate the fibrosis of the pancreas based on elastography. We can have information on the function by determination of bicarbonate secretion, but also we can have information on the dynamic behavior of the pancreas by measuring the distensibility after the administration of secretin. So today, this have really increased our capability to detect early chronic pancreatitis. But probably for me, it's also important that we have made a spin-off of this study in which we have compared elastography, which takes a couple of minutes, to the determination of the output of bicarbonate and this correlation is extremely good. So probably Elasto alone can be really very helpful to optimize our strategy to detect earlier stages of chronic pancreatitis. And probably this is a big, and it's going to become a key technique in the future for the determination whether our patients have really early chronic pancreatitis or not. But if we move to another big topic is the pancreatic tumors, we have already commented the key role in the detection, but it's also increased amazingly our capability to differentiate between different types of tumors, because it is not only, as we will see, the absolute key role in sampling tumors AUS-guided, which is the way to go, but also with the advanced imaging techniques, the capability to differentiate with elasto and contrast enhancement between the different types of tumors. If we talk about AUS-guided sampling, the very recent guidelines from ESGE absolutely recommend AUS-guided sampling as the technique of choice to obtain histological samples to differentiate between different types of tumors. And if we want to compare cytology plus histological needles, what we know is the new core needles are superior to cytological ones, mostly for obtaining adequate samples for histological evaluation. This is going to be very important, with fewer passes, and it's absolutely recommended when we don't have the possibility to do the rapid on-site evaluation. So I think today is stated and is the way to go to do AUS-guided sampling better with core needles to obtain adequate histological samples to differentiate between the different types of tumors. But there's also the role for advanced imaging, and over the last years, we know that elastography is providing a very sensitive method for the determination of malignancy. We still need to increase our capabilities on specificity because we have still some problems of learning and interpretation in cases of calcific chronic pancreatitis. The add of contrast enhancements with an hypovascular pattern provides a sensitivity over 90% with a specificity also around 90%, but probably the most and biggest information with this advanced imaging is that when we put both techniques together, our sensitivity for the detection of malignancy and our specificity is extremely high. So probably, for instance, what we have done in our center, our strategy in Santiago, is combining elastography, contrast enhancement, and T-cell acquisition to have the best diagnostic approach to try to place what is the most probable diagnosis of our solid pancreatic tumor. So this is really very important, and probably the combination of sampling and advanced imaging is going to increase our diagnostic yield to differentiate between different types of solid pancreatic tumors. But remember that we talk about the core needles providing histology with high accuracy, and this is for me very important because if we obtain good histological samples, well, what we know it is possible with the new core needles, we can do a great molecular profiling. So we can know more about our solid pancreatic tumors, we can know more about our pancreatic cancer, and probably by the possibility to perform all of these types of analysis, we can move to the personalized medicine, which for sure is going to increase our diagnostic capabilities and our treatment capabilities when we are managing solid pancreatic tumors, mostly when we are managing pancreatic cancer. But it's not only for diagnosis, it's not only for differential diagnosis. We know today that AUS is playing a key role in staging pancreatic cancer. And this very nice study coming from Yamada 2020 highlights that when we add elasto to B mode, we can really increase our staging capabilities, optimizing the detection of resectability or non-resectability of solid pancreatic tumors. So probably this is going also to induce a change in the management of our pancreatic cancer cases. But look, if we even add contrast enhancement, this study has highlighted that contrast enhanced associated to B mode, it's even better than CT and B mode alone for detection of a small liver metastasis. And in fact, in this cohort of patients, in 2% of the patients, only contrast enhanced AUS was able to detect the metastatic lesions. So this is very important to take into account for the future, and this is very recent information. But it's not only for diagnosis, staging, it's also for treatment. And now we have the possibility to do local treatment of solid pancreatic tumors. We have the option of cryoablation, radiofrequency ablation, or also local chemo treatment. So what we know regarding the treatment of pancreatic solid tumors, the AUS guided local treatment, we have the option of chemical treatment, that is gene therapy, chemotherapy, immunotherapy, with a very important technical success. In these cases that are mostly advanced diseases, we can increase a little bit the overall survival, with still some adverse events that we need to check and try to improve for the future. And when we talk about thermal treatment, that means cryoablation and radiofrequency ablation. Again, our technical success can be between 80 to 100%, with similar dates on the data on overall survival as with chemical treatment, and also need to improve a little bit on adverse events. But what is important, this is add treatment to a standard chemotherapy, and probably is an insight for the future, and probably we are on the way to really improve and have new alternatives to treat our patients with pancreatic cancer, for instance. But it's not only local treatment. Now there's a big development with new devices, mostly with the lumen approximatal stents, to treat palliative treatment of pancreatic cancer. So we have the option for gastroenteral anastomosis, and we have also the option for choledochondroduodenostomy. And this is very, very important, because we have recently very nice data with these two techniques. And for instance, gastroenteral anastomosis has shown to be better than surgical gastrojejunectomy, and also better than enteral stenting. And probably this is one of the best alternatives to treatment for the treatment of duodenal stenosis in patients with pancreatic cancer. But again, another option for failure RCP is to do an AUS-guided choledochondroduodenostomy, mostly with the luminal approximatal stents. But come on, this is a very doubtful, because now we're thinking on placing even AUS-guided choledochondroduodenostomy a first step approach, even before ERCP. I think this is not yet here, but this is something that might be new for the future in the management of biliary obstruction in pancreatic cancer. We move finally to cystic pancreatic lesions, and we know that AUS-guided sampling is really increased our capability to differentiate between mucinous and non-mucinous lesions. We've been working with THEA levels, but believe me, the determination of glycose is really improving a lot, and this is a very recent multi-center review published in GI Endoscopy, stating that really the determination of intracystic glycose is extremely good, with a very good accuracy to differentiate mucinous and non-mucinous lesion. And we have very recently conducted a study that we published in Surgical Endoscopy in 2021, in which by the determination of on-site glycose evaluation, we are very sensitive and very specific to determine whether our lesion is a mucinous or a non-mucinous lesion. But we have even the possibility to go further with through the needle biopsy. There is a quite recent technique with the first studies starting in 2018 and more coming now. And this is a review publication in Asia Journal in 2021. That this is very interesting, because with the through the needle biopsy, we can really obtain real cores, histological cores from the wall of the lesions, and we can really provide a definite diagnosis of our cystic lesion, not only mucinous and non-mucinous, but also what type of lesion it is. And this, for instance, can be very important when we manage IPMN. We can even subtype IPMNs, since we know that different subtypes present a different potential for malignancy. But of course, it is not only the possibility to diagnose and to optimize diagnosis, now the possibility to ablate these lesions. So we had information from the past on the initial effect, but now we have very, very important information on what are the long-term effect of AUS-guided ablation of cystic pancreatic tumors, and it turned to be a very important tool. And we need to know exactly what is going to be in the future the position in the treatment algorithm of AUS-guided ablation, because it's a real possibility today to treat this type of lesions. So just coming to the end to my take-home messages. I think we all agree that AUS plays a key role and has induced a change in the management of pancreatic diseases. We know that it's essential in the etiological diagnosis of acute pancreatitis. It's really improved the outcome of world of necrosis. I think it's a basic method in the diagnosis of early chronic pancreatitis, and with the new techniques, it's going to be even better. We all believe it has changed the diagnostic and staging strategy of solid and cystic pancreatic tumors, and it really provides excellent treatment opportunities in pancreatic tumors. And nothing more, invite you to the next AUS events that we will take part 2022 and 2023, and also welcome all of you to Santiago de Compostela And thanks for your attention and awaiting the Q&A. Thank you very much.
Thanks to you for this really excellent talk, which was really a firework on the new opportunities, diagnostic and therapy-wise. While people are still thinking on their question, I might start. Your nice data on glucose, intracystic glucose, do you think it's, or are the data, whether it's superior to CEA plus cytology or histology, or are there even combinations to think of?
Well, that's a very nice question. I think glycosis really make a change in our clinical practice because we can have the information in the room. So not even need to wait for the lab to come for the results. We know that cytology in cystic pancreatic tumors is not as good as we expect. We know from a lot of studies that diagnostic yield just from the cytological evaluation of the content hardly reaches 20 to 30% of accuracy. So I think glycosis is easy, cheap, very simple, and the data that we have available today is placing this technique to differentiate mucinous from non-mucinous lesion in a very good position. I still think that we need to have more because we need to know more about the real diagnosis, mostly for IPMN, because we know the management will depend, if we can, on the subtypes. But I think glycosis in the beginning, it's a simple technique, easy to spread use, and I think it's for me, better than CA levels in our clinical routine.
Thanks. There's a question from the audience. Do you use EUS for staging of a patient, suggested being operably by CT? So that was actually also my question. EUS versus CT, how do you manage to convince your surgeon to rely on your EUS versus CT?
Well, that's, I mean, I think CT and AUS are absolutely complementary in the staging strategy. I think AUS is not being better than CT or CT being better. I think we both provide very useful information. Probably for the venous infiltration, AUS is slightly better than CT. This is what is stated in a lot of data from the literature. Probably for arteries, CT with 3D reconstruction can be a little bit better, but I think we provide together very nice information. So my surgeons, probably because we've been working together for 20 years since we started with AUS, today my surgeons want always an AUS in a resectable lesion before sending for surgery, because we really provide very good information in venous infiltration, which is key, but also for lymph nodes and also for local infiltration. And what is a good insight is that we can take a look at the liver, and we are very close to the liver, and sometimes we can really detect very small lesions, not easy for the CT, and only could be comparable to the MRI, which is not the standard of care for today for the staging. So I think CT and AUS is not fighting one against each other, is both together increase our strategy to optimize the staging and the final resectability of the tumors.
Yeah, thanks. And also one last question from my side, looking at your nice data, elastography, contrast-enhanced ultrasound, differential diagnosis of small tumors or cystic lesions. What's the role of AI in this context? Multi-parameter imaging, do you think, I mean, it's has entered routine in luminal endoscopy?
Well, I think I need to tell you that I'm working on that topic. Cannot say too much because it's a little bit of ongoing concept on AE in AUS. I think we have some data coming from Carlos Robles from Ecuador in B mode. Nice data to identify different structures to try to help in the learning curve of AUS. It's true that we have some data on giving a computer the images that we obtain with Elasto, mostly with Elasto. This is a study that we've been part together with Adrian Saftoiu from Romania. And it says that we can improve a little bit the diagnostic approach based on advanced imaging when we put the data into a computer. I think we are just in the very, very beginning of artificial intelligence together with AUS and together with advanced imaging. And I think it's an open field that probably will provide some information in the near future. Believe me, it's something ongoing, but I cannot get further today because I will be killed by some of the guys that I'm working with if I tell you this information, but be ready for the future.
Okay, we definitely don't want to be you to be killed, so we better stop here. So thanks a lot. We are already a little bit advanced in the time. Thanks a lot for this very nice last talk. And now it's my turn actually to close the session. I think it was a very interesting, a very wide field of topics. And also at the end of the scientific part of the meeting, I want to take the opportunity to thank also Natalia for organizing this wonderful meeting in this really, really challenging time. And I think we all, I speak in our all names, that we are in our thoughts with you and with the Ukraine people, and wish you all the best for the future. And with that, I close the session, and I think probably will hand over to Matthias then.